Good morning, everyone. Welcome to our 8th edition of Cardiology Across Continents. We're very excited about this case-based learning series. Today we have a great case that will be discussed by our friends Hector from Children's Institute in Mexico. So Cardiology Across Continents. So this is a virtual webinar that's been hosted by partnering institutions every 1 to 2 months. The goal is to discuss challenging cases and to highlight differences in strategies in caring for these difficult patients. We increase exposure to pathology, clinical presentations, and management strategies to providers in different settings. The previous topics have included late presenting DTGA, Eisenmenger syndrome, and congenital heart block in a preterm infant, but we have many cases that we're planning in the future. So the webinar format prior to the session, so there's 2 partnering institutions. The primary institution identifies a challenging case and chooses a faculty and a fellow to present the case. The details of the case are given to the partnering institution who prepares a proposed management plan. And then on the day of the presentation, we'll start with the details of the case. The partnering institution will share their proposed management plan, and then we'll discuss the actual course of the patients, leaving time for discussion and interaction at the end. So for audience members, we encourage audience participation and discussion. You can use the chat box to pose any questions throughout the case, and then we'll have time for discussion at the end. So without further ado, welcome again to Cardiology Across Continents. We'll be discussing a 9-year-old female who presented with cyanosis. The case will be presented by Santiago Villar, Violeta Castanuel, and Hector Deliz from the National Institute of Pediatrics. Welcome and thanks for presenting. And the management will be presented by Texas Children's. So we'll ask you guys to share your screen.
Hey, can everyone see the presentation?
Yes.
Yep. Great. Well, hello, my name is Santiago Villar. I'm a medical student, and before I begin, I would like to take a brief moment to thank everyone who made this possible, and obviously to everyone at the Cardias team for the opportunity. It is a real privilege to be here speaking to all of you. So without further ado, we'll begin with a presentation. A 9-year-old girl with a history of progressive cyanosis, shortness of breath, chronic fatigue is brought by her parents to our cardiology department, looking for a second opinion after being rejected for surgical treatment at another center. She was previously diagnosed with a probable VSD and pulmonary stenosis. She was treated with captopril, furosemide, and spironolactone from the ages of 9 months to 6.5 years old. But it was discontinued because she lost access to the government program that previously gave her access to the medication. The physical examination was remarkable due to oxygen saturation of 65%, central cyanosis, and digital clubbing. Heart sounds were heard on the right side of the chest, and a 5 out of 6 hollow systolic murmur, best heard on the upper right sternal border, with a loud second heart sound. This is the initial chest X-ray. We can see an enlarged cardiac silhouette with apparent dextrocardia, a right aortic arch, bronchial situs inversus, ground glass opacities, and a left liver. The initial electrocardiogram showed a sinus rhythm, atrial situs inversus, a P wave of 80 milliseconds and 0.1 millivolts, QRS of 80 milliseconds, a QRS of 120 degrees, a corrected QT interval of 400 milliseconds, and right ventricular hypertrophy. This is her initial transthoracic echocardiogram. It showed abdominal blood vessels and situs inversus, atrial situs inversus, systemic veins connected to the left-sided, morphologically right atrium, pulmonary veins connected to the right, morphologically left atrium, an intact interatrial septum, a distended left atrium, concordant AV connection, a double outlet from the spatially left, morphologically right ventricle, with the vessels emerging side by side, and a right pulmonary artery with a left aorta. This image shows the intact interatrial septum with a distended left atrium. And in this image, we can see a restrictive 3 millimeter VSD with a left to right flow and a maximum gradient of 60 millimeters of mercury. Here we can see the double outlet from the spatially left, morphologically right ventricle. Here is the right aortic arch. And the echo also reported severe subpulmonary stenosis with a gradient of 51 millimeters of mercury. The pulmonary valve had a measured diameter of 1.4 centimeters with a Z-score of negative 2.012 and a pulmonary artery with a diameter of 1.3 centimeters with a Z-score of negative 2.318. We decided to take an MRI to further evaluate this patient, and here we can see an L-loop ventricular topology with concordant AV connection. We can also see atrial situs inversus. In the left images, we can see the left ventricular hypertrophy with mitral regurgitation, and in the right images, we can see the yellow arrow pointing to the small VSD and the green arrow pointing to the subpulmonary stenosis. In these images, we can again see the double outlet from the right ventricle, the thick ventricular septum, and the subpulmonary stenosis. We would like to take a brief moment to pause to review this entity with Dr. Patricia Bastero from the Texas Children's Hospital.
Good morning, everybody. I'm just going to present what would be the algorithm of evaluation for a standard double outlet right ventricle. I think we can all agree that the patient that our colleagues at IMP present is far from the standard patient that we see. Because we are involved with Hector, Santiago, Violeta, and the team, we meet with them, as Dan knows, weekly. I think it'll be a little bit cheating if we were to share exactly what we would do in this case, because we actually follow this case from the get-go. So just as a review, I think it is important, and just for educational purposes for those in the meeting that are a bit more junior, like Santiago, once we face a double outlet right ventricle, the first question we ask is about the VSD and how that VSD is related to the great arteries, apart from the fact that we would care about the size of that VSD as well. So based on this, as we all know, we have different type of classification, and then we call it clinical classifications or anatomic classifications, as you can see in the chart. And the most tricky of these anatomies would be when we have a remote VSD type clinical classification or a non-committed VSD that would actually affect our decision or our ability to septate these kids and go to the ventricle repair, amongst other things. When we do other diagnostic imaging, like Santiago presented, that they moved into MRI or cath or CTA, usually at Texas Children's Hospital, we will consider CTA or MRI when there are associated lesions, for example, a complex arch, or we need further delineation of that VSD commitment with the semilunar valves. We also use it for procedural long-term follow-up in certain cases. And the cath, for those patients that behave as a TEA type, we may take them to the cath lab, or we may just proceed with the BAAs at bedside for proper mixing. And then in other instances, especially when it's late presentation, and I must say that we are lucky, and late presentations like the ones our colleagues in Mexico talk to us weekly, we don't see. So we barely see a 9-year-old presenting in this situation. But that would be a case, obviously, that would take to the cath lab like our colleagues did. And obviously from hemodynamics, PA pressures, PVR. And in some other cases, we also do it for, angiography and complex anatomy. So based on the type of double outlet right ventricle we are facing, we would take different approaches and procedures. Yes, Dean, we were going to open the forum at the end, but you're welcome to speak up if you want.
After you're through, I just wanted to make a comment about the classification, but go ahead.
Yeah, no, go ahead. We can do it now.
Just so there's no confusion, your classification system you have at the top,
yeah,
is a good one. It works well for surgeons. I would just say that the VSD type can be a subaortic VSD or a doubly committed VSD. It doesn't necessarily need to be both. And usually the TOF type is subaortic, not doubly committed. Just so everybody's clear.
Okay, good to know, because we took these from our handbook, so we'll make sure to amend that.
Yeah.
Thank you. And then we'll move to the surgical intervention algorithm based on the anatomic classification. I think we all know these patients are all surgical to start with. And so for the subaortic VSD and doubly committed VSD, we'll focus on whether there is pulmonary stenosis or not. If there's VSD type without pulmonary stenosis, usually we would intervene on these patients between 6 months and a year of age. And some of them may need PA banding prior to this. When there is pulmonary stenosis or TET type physiology, we usually intervene on them around 4 to 6 months of age. Some of them, depending on the degree of the pulmonary stenosis, may need modified VTT shunt prior to their repair. When talking about suprapulmonary VSD, will depend a little bit on whether there is aortic coarctation associated or not. It's the TGA type. And so the standard approach would be arterial switch operation with an endocardiac baffle for the VSD, plus minus an aortic arch advancement based on how affected the arch would be. If there's pulmonary stenosis, then we'll have to proceed with other surgeries such as osteonechato. When we face the most complex ones, or the non-committed VSDs, or those ones like heterotaxy, like the patient we were discussing today, or that are associated with epicanal defect, etc. We have that remote VSD. We may have to palliate them, put a PA band at first if they have a good ASD and there is no PS. And then the complex repair usually is later on in their infancy, and they may have, based on whether we can sedate the patient or not, complex repair in the infancy, or they may have to go the single ventricle palliation. I think that what would be most important at this point is to see all the cath data that our colleagues at IMP found, because I think that is going to help all of us follow this case. And there's going to be interesting talks, I think, about physiology on the post-cath intervention, and then the subsequent surgical procedure. So I'm going to close it here, because I'd like you to see what happened to this patient, and I'd like to open the forum afterwards just for some input on physiology and management, then if that's okay, so we can all open the discussion once we see what the findings of this patient in the cath lab was quite striking.
Yeah, that sounds great.
Santi, you're muted.
Thank you. So first, we're going to discuss why this case is unusual. Question is, how can a patient have double outlet right ventricle, a restrictive VSD, and an intact interatrial septum and live to be 9 years old with no interventions? So as a quick recap, double outlet is a right ventricular arterial malformation in which both major arteries arise either entirely or at least predominantly from the right ventricle. It represents around 1.3% of all congenital heart disease, and some reports say that a double outlet right ventricle with a restrictive VSD can range from anywhere from 10% to 63% of all of the patients. And patients that usually have a double outlet right ventricle with a restrictive VSD will require interventions early in the neonatal period. We did a review of the literature and found a few case reports of patients with double outlet right ventricle and either a restrictive VSD or an intact ventricular septum. These are just some of the articles reporting this entity. However, this is a still rarely seen form of the disease, especially with intact interatrial septum, and even more so in a patient that lived to be 9 years old without previous interventions. So how can a patient live to be 9 years old with a restrictive VSD and an intact interatrial septum? In all likelihood, this patient probably had a larger VSD that has progressively closed throughout the years. While reviewing the literature, we found two theories for progressive closure of VSDs. The first is dependent on the location of the VSD, including the alignment of the infundibular musculature with a VSD, causing progressive closure through hypertrophy of the conal musculature, or even fusion of the AV valve leaflets to the VSD. The second is dependent on the proliferation of cardiac tissue, and this can either be by muscle encroachment with subsequent fibrosis or endocardial proliferation. This progressive closure of the VSD would explain the progressive nature of her symptoms and also highlights the urgency for surgical treatment, as further closure of the VSD would greatly limit the left to right shunting and could prove to be fatal. So what would be the best first step of management? We opted for a diagnostic and interventional catheterization. First, we would do a Rashkin to decompress the left atrium and allow for greater blood mixing in order to send the girl home and have time to evaluate her response to the procedure. Secondly, the goal was to record hemodynamic data in order to decide what surgical treatment we could offer. These are some images from the cardiac cath. During the catheterization, we found a 1.5 millimeter PFO, and it was dilated with a 9.5 Z5 millimeter balloon. And afterwards, a 13.5 millimeter park blade was used to make 6 incisions. Then two 13.5 millimeter Z5 balloons were passed through the interatrial septum. And finally, the septoplasty was completed with 2 Z-med balloons that were 20 by 40 and 18 by 40 millimeters. The angiography showed a 35 millimeter interventricular septum with a 1 millimeter VSD with left to right shunting. Severe pulmonary infundibular stenosis was identified with a peak gradient of 103 millimeters of mercury. This is the data from the cath, and all measurements were done after atrial septostomy. We would like to emphasize that after decompression, after the decompression of the left atrium, the pulmonary gradient doubled from 51 millimeters of mercury to 103 millimeters of mercury. Even after atrial septostomy, the mixing of blood in both atria was poor. This is shown by the saturation. And there was an 18 millimeter gradient between the left ventricular and diastolic pressure in the right atrium. However, the saturation in the right ventricle was better. This could possibly be due to the VSD and the left to right shunting occurring there. The calculation supported the measurements with a finding of high total pulmonary vascular resistance and low arteriolar pulmonary vascular resistance. This is the transcatheterization echocardiogram post atrial septostomy. So we can see the interatrial septum there. Now we'll review again with the Texas Children's Hospital how they would have managed this case.
Sandy, I just share our algorithm, so I think we can move along.
Great. After the cath, unfortunately, the patient was hemodynamically unstable and was admitted to the CVICU on high-dose epinephrine and norepinephrine with oxygen saturation of 76% and lactate of 4.9%. During the following 2 days, we were able to decrease the inotropic support, but the patient was kept intubated. When the pressors were reduced, the sedation doses were also reduced, and whenever the patient began to wake up, the mean arterial pressure and the oxygen saturation dropped. The oxygen saturation got as low as 55%. This raised the question of what was causing these events, and we settled on two main possibilities, either hypoxic spells or pulmonary hypertensive crises. The first would be explained by the high pulmonary gradient, and the latter due to the decompression of the chronically obstructed pulmonary veins. The patient was started on esmolol and required restarting norepinephrine. She was also sedated, as these drops in both saturation and mean arterial pressure corresponded with her arousal. This kept her stable, but we were unable to wean her off mechanical ventilation. She stayed at the cardiovascular intensive care unit for a week without improvement. So, up to now, are there any treatment options that anyone watching would suggest?
Yeah, we would like to open it to the forum now. What would you have done? Would have opened the atrial septum? Would have done any other approach, Dean?
Yeah, I was going to ask the rationale for opening the atrial septum, because it seems like what ultimately happened was that it just increased the left to right shunt. The data for that is that the gradient in the RV outflow tract increased, meaning that there was more flow across it. The actual obstruction didn't change, and that it probably developed low cardiac output. I don't think there's an explanation, or that the explanation that he has chronically obstructed pulmonary venous return is necessarily valid. And I wouldn't have expected necessarily the septostomy to have increased the SATs, at least the systemic SAT, possibly maybe by increasing the pulmonary blood flow a little bit. But so my question was the thinking for the septostomy.
When we first saw the atrial septum that also had this small PFO, to be sincere, what we thought it was to open the atrial septum to improve saturations. That was the main purpose of doing it. And what we thought it would tolerate it and go home, and then reassess the case. But I know that that opening would increase the volume load in the right side of the heart, increasing maybe a little bit the flow through the pulmonary stenosis, but really the reason for that, it was just to improve mixing and probably a little bit the saturation. That was the reason.
Yeah, I understand. I don't know that since he's not technically transposed, that mixing would be that important of a consideration with this exact lesion. But I think that what was unpredictable was the net increase in pulmonary blood flow potentially that maybe led to lower cardiac output.
Yeah, and the other thing is that after atrial septostomy, the left ventricle end diastolic pressure was 28. I think that the atrial septostomy wasn't that large, so it still had a high left pressures. The pressure in the left ventricle was 240 over 0. So that was the reason why we thought that this kid had this chronically hypertensive pulmonary veins. That was the other reason, and that's the other reason why we did the atrial septostomy.
Yep.
Okay, so the other thing, is there any other medical treatment that you think could improve the patient? Because every time we try to wake her up, the patient got sick, very, very unstable. So we already had esmolol to try to improve the flow through the pulmonary stenosis. And also the kid needed a little bit of norepinephrine to improve the saturations also. So I don't know if it could be another possible treatment. We were thinking if I know that it was the pulmonary stenosis was the main problem, but also we thought about the pulmonary veins. So I don't know if maybe adding nitric oxide or something would help with the case, or would you do anything different?
I mean, for me, it doesn't seem like there was, I'll defer to Patricia about other medical options, but, you have basically a doubly obstructed heart. I certainly don't have experience with this in a 9-year-old patient because I don't normally see patients this age. But you have a doubly obstructed heart, and you have with high EDPs on both sides, and you have preferential pulmonary vein flow going to the left ventricle, maintaining cardiac output. And then after the septostomy, I guess the RV-EDP was a little bit lower. And so the poorly compliant left ventricle just didn't fill as well. And you got into a situation of systemic low cardiac output. And I'm not sure that a medical solution was possible, really. I think of these when I see them, particularly in infancy or shortly after birth, a TET with doubly obstructed physiology of sort of a surgical emergency. I think the only thing you can really do is get the VSD enlarged. Maybe we can talk about the other surgical options for complete repair versus palliation, but I think at that point, to improve systemic cardiac output, you have to relieve the LV outflow tract obstruction surgically.
Okay.
Did you guys trial nitric at all?
No, nitric oxide was only tried after the
No.
surgery.
But
Okay.
no, in that moment, we didn't do anything else.
You said smaller.
And what was the change in saturations after the septostomy? Was it 60 to 70?
Yeah, it was really low.
Yeah.
You can increase that much. Yeah. We didn't have any result on that. Okay.
Great. So since we didn't find any other way to improve the medical treatment, we opted for surgical treatment. This was the surgery performed through median sternotomy, aortic and bicaval cannulation, mild hypothermia, and anterograde cold cardioplegia. Atrial septostomy was enlarged, and with a beating heart, a bidirectional Glenn and extracardiac non-fenestrated Fontan were performed. And a nominate vein turn-down procedure was also carried out with a 12 millimeter pulmonary pressure after weaning off bypass. The patient was transferred to the cardiovascular intensive care unit, intubated with nitric oxide, low doses of epinephrine, norepinephrine, and vasopressin by a Fontan protocol. So how did we get to this surgery? First, we would like to review what was mentioned by Dr. Bastero in the ideal case scenario for the treatment of patients with double outlet right ventricle and restrictive VSD. And early diagnosis with a possibility for VSD enlargement and a biventricular repair would be the ideal. However, this patient presented at 9 years old with a very restrictive non-committed VSD and had a 35 millimeter thick ventricular septum that was not amenable to enlargement. So we thought that biventricular repair through an enlargement of the VSD was not possible. We found many articles regarding the treatment options for patients with double outlet right ventricle. However, these two are particularly relevant to this case. So the first study concluded that extending a biventricular repair to patients with borderline anatomy, which includes non-subaortic VSD, is not always the best practice. In the second study, there were four main risk factors for poor outcomes in the modified Fontan surgery, and these included the left or common AV valve insufficiency, decreased left ventricular ejection fraction, and increased preoperative pulmonary vascular resistance, exceeding 4 Wood units per meter squared. Even though our patient had a high total pulmonary vascular resistance, and considering this is a very high-risk patient for Fontan circulation, we believed performing an innominate vein turn-down procedure could ensure minimum cardiac output in the event that our patient presented a pulmonary hypertensive crisis. This, in addition to nitric oxide, would improve conditions for pulmonary flow. As another consideration for the acute phase, as a high-risk Fontan, we expected a difficult post-operative course with prolonged pleural effusions. This could be improved by connecting the lymphatic circulation to a normal atrial pressure, assuming that the thoracic duct would present to the opposite side. This is an echo showing the bidirectional cavopulmonary anastomosis. And that is an echo showing the innominate vein turn-down procedure. So after surgery, as I mentioned earlier, the patient came out with epinephrine, norepinephrine, and vasopressin. She had a lactate of 1.1 and oxygen saturation of 80%. And although our regular protocol includes early extubation in the OR, in this particular patient, she was admitted to the CVICU on mechanical ventilation due to the administration of nitric oxide and was weaned off mechanical ventilation on day 4. The right and left pleural drains were removed on the 5th and 6th postoperative days. She had a total cardiovascular intensive care unit stay of 10 days and was discharged home on day 23. We reached out to the patient's mother last week, and she referred a marked improvement in quality of life, no shortness of breath in day-to-day activities, and she is now able to participate in her PE classes, and she has had no need for intervention or hospitalization ever since.
Thanks for sharing. Could you talk a little bit more about the innominate vein turn down procedure and the thoughts behind doing that?
Yeah, well, first, as a high-risk Fontan, thinking about the pulmonary problem in a 9-year-old without any other procedures, well, and the rationale that this patient could have hypertensive crisis because of these pulmonary vein obstructions first, I thought that if this kid had a lung problem, although we used nitric oxide, I wanted to ensure cardiac output. So a merely a classic penetration. Well, the experience with that is maybe they could get closed in the post-op, immediate post-op due to the high hematocrit or something. So I wasn't sure that it was the classic penetration would be the correct answer. So for the acute phase, I wanted to guarantee at least a minimum cardiac output with the innominate vein turn down, and also to had a low pressure in the lymphatic system, connecting the innominate vein to the directly to the atrium. So I think that was in the acute phase, and then in the long run, well, sometimes here in Mexico, as we see cases out of the classical age, also, I think we're a medicine of one shot treatments. So many of these patients get lost in the follow-up. So I thought that this could help her with lymphatic decompression in the long run and save her from the problems of plastic bronchitis or so. That was the main reason for the innominate vein turn down. So it was kind of a bailout in this patient in a high risk spontan.
Great, thank you. Does anyone else from the group or audience have any thoughts or experience with the innominate vein turn down? Would anyone have just done a fenestration in this patient?
You know, I know that well, she had a good PAs, but the total pulmonary resistance were 8. That I thought of it. Well, my conclusion was that the atrial septostomy done by CAT wasn't a good one. So she still got a high total pulmonary total resistance, but the arterial were very low. So that was my shot.
Mm-hmm. Did you guys discuss doing a 2-stage repair instead of just the 1 stage?
Yeah, we discussed it, but it's a 9-year-old, so I think that doing just the gland would keep her very desaturated. So, oh, there's also the option of doing the fontan, the graft, and not doing the gland. But I thought once again, if this kid lost to follow up, well, I just thought I will give her all the way.
Sure. Dr. McKenzie, did you have another question?
I did. Well, first of all, congratulations on really improving this girl's quality of life. That's a great outcome for such a difficult situation. I'm not sure we could have done any better. We might have chosen a different surgical option, but I don't know that we would have had a better outcome. Maybe I'm not understanding the anatomy properly, but does she not still have LV outflow tract obstruction?
Sorry?
Does she not still have left ventricular outflow tract obstruction?
No, there was no obstruction. There was no subaortic stenosis or obstruction.
Oh, I thought you said her LV pressure was 240.
No, in the left ventricle. But both both vessels were arising from the right ventricle. So the pressure between the right ventricle and the aorta were the same. It was the systolic pressure in the right ventricle of 130 and the same in the ascending and descending aorta.
But is the left ventricle not still hypertensive?
Yeah, the left ventricle is still hypertensive. There was a discussion of closing the mitral valve, but still it will keep the ventricle hypertensive. It's still hypertensive, I know, but the only thing we thought of was enlarging the ASD and trying to decompress the vest with just lowering the end diastolic pressure. I don't know. It was it was difficult to take that decision of closing or not the mitral valve.
Yeah, that would be a difficult decision. That left ventricle, though, is going to be quite a liability going forward. The myocardium will be, potentially ischemic at times, but that's, I guess, what you had to do. I wanted to, Dan, and I hope you'll give me the hook if you think I'm out of line here about the morphology. It was mentioned that he was L-looped, and I'm not sure that's correct. Because you can have dextrocardia and not have L-looping.
Would you guys mind pulling the echo up again so we can look at it?
With dextrocardia, it changes the topology. So you go from left-handed topology to right-handed topology, but it doesn't necessarily change the looping necessarily. And it's important or relevant, I think, because if you decided to enlarge the VSD, the ventricular looping impacts the location of the conduction tissue. In this patient who has dextrocardia and is also D-looped, he would have a normal posterior conduction system. So I think we shouldn't think of this patient as being L-looped. He has left-hand topology.
Okay.
No, right. He has right-handed topology, but he's in dextrocardia, but he's probably D-looped. That makes sense.
Okay.
And the only reason I bring it up is just because I was thinking that we potentially may have tried to enlarge the VSD and either as in a stage to a biventricular repair or a single stage repair, and then that would have affected where we would have enlarged the VSD.
Yeah, well, one of the thoughts of that was that it was a very thick interventricular septum. They measured 35 millimeters. The few cases where I enlarged the VSD, well, it's it's not that thick, and you know where to do the cuts not to get it in problems. Also, we read a lot about this, and they say if it's a subaortic conus that is causing the problem, you can do all the enlargements in that muscle and don't get involved with the conduction system. So the thing is that I really was scared of that thickness, and if I could do a good enlargement, that was the main problem.
Yeah, I'm not blaming you for not doing that. We may have done the same because that's, we don't have the experience with these delayed presentations like you do.
So
Right.
Dr. McKenzie, excuse me, are you saying basically it's Normally loop just inversed, everything's inversed with normally
Yeah,
related.
the situs inversus totalis,
Yeah,
dextrocardia, but it's de-looped. So you can have dextrocardia without L looping. Is all I'm saying.
okay.
So the other question that I have from this case is that I read a lot about lymphatic circulation in congenital heart disease and in patients with dextrocardia and everything. And it's nothing that it's clear. So I thought that it was a mirror image, thinking that the thoracic duct will run through the right side of the chest. So I know that a fenestration, a classic fenestration or also could be an answer to decompressing the systemic veins. But do you usually assess the lymphatic circulation in the content patients? Or when do you think a patient, a high-risk patient would need a fenestration to help her in the, I don't know, what
When to fenestrate, basically.
No, I know, but when do you assess the lymphatic system? When do you think a patient is gonna develop, or you studied the lymphatics after they have problems?
Yeah, we don't routinely preoperatively. Obviously, every Fontan behaves differently, and sometimes we end up with chest tube output that doesn't decrease, or calothoraces, and that will prompt us to study the lymphatic system. But we don't necessarily do it preoperatively, even if they're a higher risk. I think that I suspect that a lot of this patient's pulmonary resistance issue was related to the high EDP and not so much to intrinsic pulmonary vascular disease. And in that case, the fenestration or the innominate vein turn down isn't as beneficial, because you're not really bypassing the problem. You still have a high atrial pressure afterwards. And so I guess my threshold to use a fenestration or something like an innominate vein turn down is a lot higher when I feel like the high resistance or is due to a ventricular issue and not a intrinsic pulmonary vascular issue, if that makes sense.
Yeah.
I wonder what will happen to this innominate vein turn down. You know, in the 70s, Bill Norwood and Marshall Jacobs in Philadelphia were doing hepatic vein exclusion Fontans, where they would leave the left hepatic vein on the systemic side of the circulation and incorporate the right and middle hepatic veins into the Fontan circuit. And the liver's smarter than we are, and it just developed a bunch of systemic collaterals through the liver, and then later reversed the shunt, and then created a problem in the future. I don't know if there's a long-term follow-up with these innominate turn downs, if the same thing will happen in the brain or the neck.
Okay, yeah, well, also a little bit of the rationale of that is we're draining the lymphatics into a more physiologic atrial pressure. I know that is high. They measured around 9 in the cap, 9 millimeter of mercury in the cap. So that I think that it's a little bit more physiologic. I know that it's a fontan and the remodeling and all that happening in the ventricles will increase the atrial pressures, but I don't know. I think it's something that needs more time to the way you say it.
This is Manish Bansal. I'm one of the interventional cardiologists here at Texas Children. With regards to lymphatic, I don't think we, at least here, we do pre-Fontaine lymphatic evaluation. There are some studies from CHOP where they do a lot of pre-Fontaine evaluation and based on the lymphatic anatomies, some of them, they don't even offer Fontaine palliation and directly go to the heart, transplant route. With regards to doing the innominate vein turn down procedure, even at CHOP, I don't think they do it as a prophylactic measure that is sort of considered as a last resort kind of thing. I also wonder in this patient whether it would be before doing the innominate vein turn down, a lymphatic evaluation is necessary because we don't really know the thoracic duct is going to open to the left side or right side, or there might be two bilateral thoracic duct, and who knows, the thoracic duct might be actually opening to the left venous angle, and we, the innominate vein turn down in this patient was on the right side. So I would probably do a lymphatic evaluation first before proceeding with the turn down. So that at least then we know whether anatomically it was the right thing to do or not.
I think Manish, she was using it as a fenestration type thing more than a lymphatic drainage issue.
Yeah, the main reason was that to allow a minimum cardiac output.
Right.
Because
Okay.
I also can say that I had cases, high-risk patients with older patients that we knew they had pulmonary problems and still didn't do any kind of fenestration, and the patient died. So I was very afraid of this very late presentation with this unusual anatomy, and I don't. The main reason of presenting is how a 9-year-old got alive all this time, and how we could offer a secure procedure. So that was the reason for presenting the case.
So we have a few more minutes. I'd like to open up to any of our other audience members. Any thoughts, different strategies, similar cases that anyone wants to discuss?
I have a question from you. Do you use vasopressin in the post-op for reduce the pleural effusion?
I'm sorry, I didn't hear that very well. Would you mind repeating the question?
If you regularly use vasopressin infusion after Fontan surgery.
Then I think that question is more for you and Cincinnati, because
Okay,
they know that we do. So.
Yeah. So
yeah.
they let us asking. Yeah.
I wouldn't say is anyone from Cincinnati on, would like to answer? I think they were on.
Yeah, they are on.
Well, in my experience there as a fellow, we wouldn't do it on every patient, only when we needed to. It wasn't something that we automatically did. So more when we needed to. Do you guys routinely do it in Texas for every patient, or?
Most patients, yeah, we started a few years back.
Okay.
Yeah, it's pretty routine. When most of our Fontans are not these extreme situations like this. They're 4 years old. They're about 15 or 16 kilos. And, if I was weaning a 15 kilo 4-year-old after an ASD repair, I would need probably about 75 to 100 cc's in the reservoir to get them off bypass, to fill them up. And turn off the pump. But if you're weaning a 4-year-old 15-kilo Fontan bypass, you're probably going to need about 700 cc's because the venous capacitance. And so, and that's in order to have, you know, a full tank, cardiac output, and blood pressure. And so it just helps us in the immediate post-op period and in the immediate ICU period to just limit the volume resuscitation. Really is what it's for, and it helps us get off bypass with 400 or 500 in the reservoir, and maybe saves a blood transfusion too.
I do see the Cincinnati conference room that I recognize. Anyone from Cincinnati want to make any comments?
Yeah, sorry, it took us a while to get to the mute button.
No problem.
It's as you remember, we don't routinely use vasopressin post-op in Fontans, but in select cases, but certainly is emerging evidence for it.
Thanks. I had one quick question. This is kind of going backwards, but did you guys consider ballooning the pulmonary valve in the initial cath, given the saturations?
Okay, no, we didn't. No, the thing is that I don't know how that muscle will respond in a 9-year-old.
So it's mostly
our
subvalvular.
first line of thinking, you know, it was
Sure.
just decompressing the
Yeah.
left atrium and
Sure.
that was it.
All right. Any final comments or thoughts? Congratulations on the case. Seems like a really great outcome.
Yeah. So we really hope to present some other cases that we'd have here.
Yeah, sure.
Not necessarily late presenters, but
Yeah.
with different scenarios.
Yeah, I learned a lot. Thanks for presenting that.
Yeah, thank you for saying that. That's what happens to us when we do these telerounds twice weekly with them. We learn a lot from them. So thank you, Hector, Violeta, Santiago. I see Alex is there too. Well, Edgar, Irene. There's a lot of people that we interact with on a weekly basis, and I must say that when we saw the data after the atrial septosis, I think I met this girl after the cath already intubated in the ICU, and I heard the data on the cath, I almost faint. And then I kept asking, are you sure she's 9? Like, how is it possible, right?
Yeah.
There you go. So yeah. And great job, Santiago, medical student. I'm sure you have a future colleague there.
Yeah, of course, and he's learning his steps and everything for a residency over there, fellowship over there.
Excellent. Good job, Santiago.
Thank you so much.
And
All
thank
right.
you, Dampec, for putting this together and for including Texas Children's Hospital
Good.
in this amazing webinar series. So looking forward to the next one. I included our partners from the other hospital in Mexico and our partners from Brazil, and they're all very, very happy to present. So I'm sure we'll be in touch and do a few more cases. Hopefully not as challenging as this one, or maybe yes, because we'll learn,
Yeah.
right? So.
All right, great. We'll keep everyone updated and let us know if you have any good cases.
Okay.
Thanks again.